Um, so just a couple notes before we get started. If you're not speaking and you don't have a question, please mute your microphone. We also encourage you, if you're able and if your bandwidth allows, to keep your camera on to make the lecture a little bit more interactive, especially during the question and discussion portion of the lecture. We will have questions at the end. However, if you have any questions throughout the lecture, feel free to raise your hand or type your questions into the chat. I will be monitoring the chat throughout the whole lecture as well as during the question and answer portion. If anybody has any questions, feel free to let me know. All right, so I am going to pass it off to Scott to introduce our speaker for today.
Great, thanks, Erin. First of all, I just wanted to welcome all of you from different parts of the globe who dialed in today for what I think is our 6th bi-monthly Partners in Health Dana-Farber Cross-Site Oncology lecture. And I think today's lecture actually marks the beginning of our 2nd year doing this series. And we're really thrilled that it seems to have taken off and that people seem to always join us. At this juncture, I also wanted just to recognize Erin Durkin, who did the initial intro. Erin really works tirelessly behind the scenes, kind of pulling together all the logistics and legwork to pull this conference off, as well as so many of our trainings and tumor boards that all of us benefit from. Anyway, today I'm delighted to welcome Dr. Eric Krakauer to our joint conference, who's going to give us a lecture titled Integrating Palliative Care into Cancer Care and Healthcare Systems in Low-Income Settings. In this lecture, Dr. Krakauer will share both the challenges and the opportunities in developing palliative care in low-resource environments. Dr. Krakauer, as many of you know, is the director of the program in global palliative care and an associate professor of global health and social medicine at Harvard Medical School. He's also an attending physician in the Division of Palliative Care and Geriatrics at the Massachusetts General Hospital. Dr. Krakauer has published very extensively for a couple decades now on both ethical and medical issues in palliative care and end-of-life care issues, and has received really wide recognition for his many important contributions in improving global palliative care. So without further ado, I turn this over and welcome our guest, Dr. Krakauer.
Thank you so much, Dr. Treidman and Erin Durkin. It's really a pleasure to join this PIH cross-site joint oncology project, ECHO. And thanks to the Center for Global Cancer Medicine at Dana-Farber Cancer Institute. It's wonderful to see so many friends and colleagues. For our colleagues in Rwanda, Muramutse, Amakuru, and hello to colleagues from Malawi and Lesotho and Haiti and other places. I would like to talk about palliative care, which I've had the privilege of working on with PIH for some time. So I will share my screen, I hope. Yes. Okay. So yes, so I'd like to begin, as I always do, with patients, because I think that's why we're all here, is because of the patients. And this was a patient I encountered in Vietnam, who had no access to palliative care, and specifically no access to opioid for pain relief. And this baby was, I think, upset for a variety of reasons, because of the pain of the Burkitt lymphoma, because of the pain of the biopsy, which had been done earlier, because of being in a frightening setting coming from a village, because of having a Mzungu taking her picture probably, and also when the patient is suffering, the family is often also suffering, suffering emotionally and often suffering financially, because as you know, it can be very expensive to travel to the cancer center, and family member needs to accompany the patient. So this can be financially catastrophic for the family. So lots of suffering. I don't take money from private industry, no conflicts of interest. So at the end of this 40 minutes or so, I hope participants will be able to discuss the medical and moral imperatives of integrating palliative care into cancer treatment and into healthcare systems in general. And I'll also mention the financial benefit, because that's often what matters most to leaders in ministries of health, and also explain the World Health Organization essential package of palliative care. Okay, so what's palliative care? This is still being debated, but I'll tell you what it is for me, and it's based on the WHO definition, but that definition is also being discussed. It's really very simply prevention and relief of suffering. And I have written here suffering of adults and children living with serious illnesses. Even that's been debated, because there are plenty of people, for example, people caught in uh, humanitarian crises, whether it's political conflict or earthquakes or hurricanes or floods, who don't have serious illness but are suffering a lot. So I think it's just most basically prevention and relief of suffering. And although that might seem simple, it's in a way very different from the standard Western approach to medicine, which tends to focus increasingly on one organ, like the heart or the lungs or the kidneys, or one class of diseases, like cancers or infectious diseases or rheumatologic diseases, or a technical skill like surgery or radiology or pathology. And I think palliative care became necessary because it's very important to think about the whole patient in the context of the family and the society. And this is also why I think it wasn't difficult for Paul Farmer and people and PIH to appreciate the importance of palliative care, because you've been doing that forever, recognizing that patients suffer socially and psychologically and spiritually, as well as physically. Palliative care to me is an essential component both of primary care and specialized care, both during treatment and at the end of life. So there's another important point. Palliative care is not only for the end of life. It's not only people at the end of life who suffer. It should be provided by primary care doctors and doctors, specialist doctors like oncologists, but also surgeons and many others. And it should be provided in any context, from the hospital to the patient's home, because most patients with serious illnesses are at home. They're in the community. So I'll talk about how to make that possible. In 2014, the World Health Assembly, which is the governing body of the World Health Organization, resolved or unanimously passed a resolution on palliative care. So coming up on the 10th anniversary of that. And the resolution stated, I should just mention that when a resolution is passed by the World Health Assembly, it becomes the responsibility of the World Health Organization to implement that resolution. So in a sense, the World Health Assembly is the governing body of WHO. And the WHO, World Health Assembly, resolved that palliative care is an ethical responsibility of health systems, not an option, not something that can be added if there's some money left at the end of the year. It's an ethical responsibility. It also said that it's an ethical duty of health professionals to alleviate pain and suffering of any kind, physical, psychosocial, spiritual, irrespective of whether the disease or condition can be cured. It's especially important to integrate palliative care into primary care, again, because most patients who need it are at home, and efforts to minimize diversion of controlled medicines like morphine for illicit purposes must, quote, not result in inappropriate regulatory barriers to medical access. In other words, anyone who needs morphine for pain should be able to get access to it. And that, as you'll see shortly, is not happening around the world. So there's no dichotomy between palliative care and disease-modifying interventions for patients with serious illnesses like cancer. So, for example, chemotherapy, radiotherapy, surgery often can be palliative. A lot of the chemo and the radiation therapy that we do is palliative. On the other hand, palliative care, by treating symptoms and adverse effects of treatment, can improve adherence to cancer therapy and potentially reduce cancer morbidity and mortality. And this has actually been shown, and I'll talk about that. Therefore, cancer treatment and palliative care should be integrated, even in patients who are being treated with curative intent. They often are suffering and would benefit from palliative care. So this was a study done at my hospital, Massachusetts General Hospital here in Boston, now a long time ago, 13 years ago. And it was a randomized controlled trial. Patients with newly diagnosed metastatic non-small cell lung cancer were randomized either to usual care or to immediate palliative care consultation along with usual care. So the usual care arm meant that they usually got chemo, and it was up to the oncologist to decide whether to request a palliative care consult. If the oncologist did request palliative care consultation, it usually only happened in the last days of life, sometimes the last hours of life. Whereas in the intervention arm, we immediately saw the patient, just one of our team. We didn't do anything special. We just provided palliative care consultation. We did what we always do. And then we followed the patient in the outpatient clinic when they came in for their chemo or for their checkups. We would see them in the outpatient clinic along with the oncologist. And if they were admitted to the hospital, we'd also see them in the hospital, doing nothing unusual, just what we always do. The result was that, and these patients were followed till the end of, till they died. The result was that the patients who got early palliative care had a lower prevalence of depression, a better quality of life, statistically significant decrease in depression, improvement in quality of life, were less likely to get chemo in the last 2 weeks of life, and lived on average 3 months longer. I'll repeat that. The patients who got early palliative care integrated with their cancer treatment lived longer, significantly longer. So this was kind of a watershed moment because this was published in newspapers. It was become very well known. So patients started coming into oncology clinic saying to their oncologist, I want some of that palliative care so I can live longer. And our clinic exploded and our entire service exploded. I started here at Mass General in 1997. There were 5 of us. Now our team is the busiest consult service in the hospital, and we have over 100 staff doing home care, doing outpatient, doing inpatient, doing research. It's taken off. So palliative care is an ethical duty. I would say that palliative care, that cancer care without palliative care is not as medically effective or compassionate as it should be, and it doesn't fulfill what many think is a human right to palliative care. In the wake of the resolution on palliative care from the World Health Assembly, a Lancet Commission on palliative care was convened. The chair was Felicia Knoll, and the co-first author of the report was Paul Farmer. And you may recall that back in around 2007, based on some well-intended but misguided comments by some palliative care leaders, Paul wrote that palliative care is often like second-rate care for the poor. And this was based on comments that some well-intentioned people made, particularly before PEPFAR, that palliative care was the only feasible and compassionate response to AIDS in Africa, which, as you can imagine, made Paul incredibly angry, as it should have, and any of us who work in those settings. But when it became clear what palliative care is, and that those comments were just a reflection of misguided people who've never been out of either out of a rich country or out of a five-star hotel, if they've been to a poor country, that doesn't reflect what palliative care is or should be. And so he was the co-chair of the Lancet Commission. The results of that commission were also summarized in this document from the World Bank called Disease Control Priorities. And this document is designed to provide advice to ministries of health around the world on what are the highest priority interventions. There are 9 volumes. There's one entire volume on cancer. The 9th volume is the highest priority interventions that every Ministry of Health should fund. And one of the sections is on palliative care and pain control. This is open access, available at this website. So part of our work of the Lancet Commission was to estimate the global burden of suffering, which is another way of saying the global need for palliative care. And I won't go into a huge amount of detail here, but we distinguish between, we use data from 2015, and we distinguish between patients who died of one of 20 conditions, the ones that most commonly generate a need for palliative care. So those who died from one of those 20 conditions in 2015, and those who had the condition but didn't die of it in 2015, called non-decedents. And based on thorough literature search and then expert opinion with experts from countries of all economic levels, mostly low and middle income countries, these were the numbers we found. This analysis has been repeated, and the numbers didn't change too much, other than there was a decision that not everybody who had HIV needed any sort of palliative care. So the HIV numbers went down. But you can see that where the black arrows show, those are the usual conditions with which one associates palliative care. So malignant neoplasms, cancer, HIV, chronic cerebrovascular disease, chronic lung disease. But then some of the red arrows point to MDR-TB, from which people may suffer a lot, not only from the disease itself, but from the treatment. And again, I think Partners in Health was providing many aspects of palliative care. In fact, I learned how to do social supports from PIH. I'll get to that in a moment. Also, low birth weight, severe prematurity, and birth trauma. So I've seen so often very premature infants with very low chance of survival coming to hospitals, and all the staff know how to do is, with whatever equipment they have, maybe one CPAP machine or maybe one ventilator or maybe neither, trying to resuscitate when the baby is moribund, and an important time for palliative care, both for the baby and for the family. Or injuries. So often I see traumatic patients with traumatic injuries, long bone fractures in the ED getting no analgesia and inadequate post-op analgesia, or for example, dressing changes with burns, severe pain, all of which can have other side effects. So the total was 25,000, over 25 million patients in need of palliative care in 2015 who died, and another 35,000 who needed palliative care who didn't die, or a total of over 60 million. I keep saying 1,000. 25 million who died, 35 million who didn't, a total of 61 million people who needed palliative care in 2015. And essentially, palliative care is accessible in rich countries, and it's rarely accessible in low and middle income countries. On the Lancet Commission, we got more specific. We made estimates of the prevalence of each major type of suffering and the duration of each type of suffering. And this allowed us then to determine what was needed to respond to all of this suffering. And that also allowed for ministries of health to calculate the cost of palliative care.
Already think I'm evil and I'm mean to you. So I
So
knew that the only way to protect myself is to
if everyone
come
could mute, if you're not speaking, please would appreciate if you could mute your microphones. Thanks. So these are the types of suffering that we studied: the physical types, psychological types, social types, and spiritual types. And we only were able to quantify, to provide estimates of the physical and psychological types of suffering. So this just gives an example. This is just cancers. The only condition reported here is malignant neoplasms, and only 4 types of suffering. In the red, moderate or severe pain, there were a total of 7.5 million patients died in 2015 of cancer, and we estimated that 80% of these, or about 6 million, had moderate or severe pain for, on average, 90 days. This is in the red. And those who didn't die but had cancer, another 7 million, approximately 20% of them had moderate or severe pain for on average 90 days. And we did this with all the different symptoms, with dyspnea, nausea, vomiting, depressed mood, and all the other physical and psychological symptoms. Okay, so huge numbers. Now, we don't have a really good measure of access to palliative care. And one of the surrogate measures is opioid consumption. And this is measured in oral morphine equivalents. That means whatever opioid was given can be converted mathematically to the equivalent dose of oral morphine. And then we calculated the average oral morphine equivalent dose per patient with serious suffering per year. So how much did the average patient with serious health-related suffering consume in oral morphine equivalents per year? And you can see Canada was 68,000 milligrams. And the US just a little less. Western Europe, 18,000 milligrams. So lots of a consumption of opioids. Well, let's look at the rest of the world. So Uganda, which is often thought of as the country with the best palliative care in sub-Saharan Africa, except for South Africa, 53 milligrams. Now, again, this was 2015, and the situation has probably improved a little bit, but 53 milligrams is less than 2 days of a starting dose of oral morphine. India, even less. Even though the state of Kerala is famous for its palliative care, countrywide, less than 2 days, on average, less than 2 days of a starting dose of oral morphine. China, Russia, most of the developing world, essentially people who have serious health-related suffering don't have access to palliative care, to pain relief or palliative care. Again, using opioid consumption as a surrogate measure of access to palliative care, which is very problematic, but one of the ways to measure access. So 83% of the world's 7 billion, now it's more like closer to 8 billion people, rarely have access to palliative care. Most of the world's opioids are consumed in high-income countries, and only 9% of the world's opioids are consumed in low and middle-income countries. And the results, these are the results. And I don't mean to shock, but actually I do mean to shock. The patients in the corners, those photos were taken by me. Patients who had obviously severe, very advanced cancers with very severe suffering. Look at the patient in the bottom right corner. Not only was there severe pain, but this tumor was invading the oral cavity and the throat, and I was very worried that she was going to close her airway, a young patient who would obviously suffer a lot. No access to pain relief or palliative care. And in the middle is a photo I borrowed from Partners in Health, a patient dying of tuberculosis. So these are the folks who are suffering for lack of access to inexpensive, effective pain relief and palliative care because there's just not enough funding and training to provide this simple, cheap, effective intervention. Now, when should palliative care be provided? You see from the time of diagnosis, especially in low and middle income countries, where patients often present with advanced disease, palliative care is often needed immediately, along with disease treatment. And palliative care and disease-focused treatment can go on simultaneously and should be integrated. Then at the very end of life, maybe palliative care is the only useful treatment, or if the disease is curable, then palliative care may no longer be needed. And then bereavement support is also a part of palliative care for family members who may struggle with bereavement. Often if it's a sudden death, a violent death, death of a child, or death in the setting of psychosocial trauma, there may be needs for bereavement support. So based on the work of the Lancet Commission and the resolution, WHO got busy and provided some guidance documents. The first one on the left, the blue one, was published in 2016, and I was able to contribute to that. And the other three I edited during my time at WHO. So these are available online, and we tried to make these very practical. I particularly recommend these two, integrating palliative care into primary health care. There's a lot of specific guidance there. And then we also did documents on integrating palliative care into pediatrics and into response to humanitarian crises. And there's also a document explaining in detail why palliative care is an essential function of primary health care. These documents contain an essential package of palliative care. And that's what I want to spend the last part of this talk on. What is the essential package of palliative care that is designed to be implemented anywhere, to be feasible financially, medically, and requires only basic training in palliative care, defined as on average about 30 or 40 hours, 30 to 35 hours of training. And it consists of these 6 elements and designed to be covered by public health insurance, at least all parts, all of these elements, except maybe the social supports, which typically would be provided by a ministry of, well, either covered by public health insurance or funded by a ministry of social care or social supports rather than Ministry of Health. So the interventions, number 1, very simple, prevention and relief of pain and other physical suffering, whether acute or chronic, psychological suffering, whether acute or chronic, again, meaning anxiety, depression, delirium, dementia, social suffering, acute or chronic, and spiritual suffering. Number 2, the medicines. So the WHO has a model list of essential medicines for palliative care, but that we thought was too extensive. And WHO is required to put on that list the medicines that are the best studied in each class. And some of those medicines are not very readily available. They just were the ones that were best studied. So our list is slimmed down to the most necessary ones to prevent or relieve the specific symptoms and types of suffering most commonly associated with serious illness. The ones that are safe to prescribe and administer by doctors, nurses, clinical officers, felchers, assistant doctors, with basic palliative care training. So not a lot of training is needed. And these are the medicines that offer the best balance in their class of accessibility on the world market, clinical effectiveness, safety, ease of use, and low cost. And these are the medicines. And again, all of this is available online. You can go to these documents. You can just Google WHO, palliative care, primary care, or use this website. And I'll just emphasize 3 or 4 of the medicines here. Morphine is perhaps the most essential of the essential medicines. And the most important are the oral immediate release form and injectable. And we have a big effort among some colleagues to try to assure that oral immediate release and injectable morphine are made available and accessible before the expensive sustained release products are put on the market. And of course, drug companies try to influence ministries of health to sell their high-priced extended release oxycodone or fentanyl patches, and they try to market them so that patients are made to believe that they're better than just plain old morphine. And the result is that poor people are selling their possessions and having financial catastrophes to buy medicines that are no better than the cheapest ones. So I would emphasize that oral immediate release and injectable morphine should be accessible. I'll also mention metronidazole. In work I did on cervical cancer, also with WHO, one of the most, besides pain, one of the most distressing symptoms is malodorous vaginal discharge. And we found in our work that oral metronidazole tablets placed carefully vaginally can eliminate the malodorous discharge and thereby treat the psychosocial distress that can go along with that. So that's also a very important medicine. And then medicines for psychological distress, fluoxetine, or any of the selective serotonin reuptake inhibitors. Anxiety and depression are very common among people with serious illness. And any doctor with basic training in palliative care should be able to diagnose and treat uncomplicated mood disorders. It doesn't require psychiatrists, and psychiatrists often are not available. So we should be doing this. Haloperidol has many uses for nausea caused by an emetogenic toxin. It's actually first line for that, but also for anxiety without causing sedation, and for agitation, a very important medicine. So all of these are on the list. Equipment is very simple. In addition to the basics like gauze, pressure reducing mattress, and we don't mean an expensive one. We talk about any way to reduce pressure, to reduce risk of pressure ulcers. So for example, in Vietnam, we use a mat that's designed for babies to play on, but it's covered with plastic so it can be easily cleaned, and it doesn't reduce pressure a lot, but it can help. Opioid lockbox. When controlled medicines are available, it's very, and they must be, it's essential that they are, we need to be sure that they're not diverted, that no one takes them or uses them for a non-medical purpose. So it's very important to have an opioid lockbox that allows the opioid to be accessible when needed for medical purpose, but to prevent diversion. And then adult diapers, we have a project now to create ecologically friendly, inexpensive adult diapers. The current adult diapers tend to be neither. They're expensive and they're not ecologically friendly, but incontinence can be a huge burden both for patients and for guardians or for family caregivers. So this is a really important intervention. Adult diapers can be made out of cotton and just plastic, like we use sometimes we cut open plastic garbage bags to make adult diapers and to reduce the burden on family caregivers, and also help reduce risk of pressure ulcers. Social supports. Again, I learned this from PIH. In fact, I have here now in Boston visiting, working on his master's, Mr. Atupere Firi from Neno district in Malawi, where I worked some years ago. And the POSER project in Malawi, in Neno, was so impressive to me that I used that as my model. And when I looked for the literature on social supports, there was very little. So this is really based on, this is PIH contribution to global palliative care, one of them. So it includes these items and we put in the essential package and in the Lancet Commission report and in the WHO guidance that these supports should be available at least for every patient living in extreme poverty and for any principal caregiver of a patient who's living in extreme poverty. Also part of the essential package is training. Basic training should be available for all medical and nursing students and all general practitioners and primary care doctors. The basic course that we recommend lasts about 35 hours, and we're working to have that course online through WHO. We've provided it in Haiti and in Rwanda and in Malawi, and we're happy to try to arrange to provide it for others. The intermediate level training we recommend for specialists, physician specialists who work with patients with serious illnesses. So certainly oncologists, but also internists, cardiologists, anyone who works with patients with serious illness. And then ideally, every country should have, at least at its major cancer centers, a specialist in palliative care. And our hope is to help colleagues around the world develop regional specialist palliative care training programs. So one place where we've started that is in Vietnam, where we've created a specialist palliative care training program for Vietnam, and we're planning to open that to the Southeast Asia region. In Latin America, this is now offered, for example, in Chile. And what services ideally should be available? Well, at referral hospitals, ideally, a multidisciplinary palliative care team led as soon as possible by a specialist in palliative care, otherwise by team members, multidisciplinary team, including social workers, psychologists, nurses, with intermediate level training, ideally. District hospitals, ideally a small team, at least a small team, maybe only doing part-time palliative care, but with ideally intermediate level training, or at least basic training with doctor, nurse, and social worker. Community health centers, again, the staff there should have at least basic training, whether there's doctors there or not. The nurses should have some basic training. And then, very important, the community health workers, trained even just with a few hours. An experienced community health worker can learn to recognize and report inadequately relieved symptoms, provide emotional support, and maybe also recognize if morphine is being used appropriately or not, and then serve as the eyes and ears of their supervising nurse or social worker at the community health center. So this is the recommended structure. And then very important is the standard operating procedures. So for example, in a pilot project we did in Rwanda, we found when we set up the structure that I just mentioned, that the structure was not working well because the community health workers and the staff at the health centers and the hospitals did not have airtime to communicate with each other, and the nurses at community health centers didn't have gas for the motorbikes to go visit patients at home when it was needed. So these seemingly simple problems were causing the whole system not to work. So there needs to be good communication between levels, and that needs to be adequately funded, and the referrals need to run smoothly from home to hospital, from hospital to home. For example, when a patient is transferred from a cancer center to the home, it's very important that the community health center that will then look after that patient receive the information they need to look after that patient at home. And they need, including what symptoms does the patient have, what medicines are they on, and what is likely to happen. Might their pain get worse? Might they start bleeding? Might they have a bowel obstruction and start vomiting? Might they develop shortness of breath? And what to do about that. So all that information should be sent then from the hospital with the patient to the community level, or maybe to the district level, so that if some of those things happen and it can't be dealt with at the home, it can be dealt with at community or district level without the need to travel often across the country back to the cancer center at Butaro or at Kanombe or at Queen Elizabeth in Malawi or Mirabale. So finally, the cost. So we studied the cost of implementing this package in countries of 3 economic levels. The low-income country was Rwanda, the lower middle was Vietnam, and the upper middle was Mexico. And to implement the entire package without the social supports, it would have, in Rwanda, it would have cost over 3% of the total health expenditure and almost 9% of the total public health expenditure. But in the middle income countries, it was just 1% of the total public health expenditure and 0.5% of the total health expenditure. And this is the cost of the social supports in the middle income countries. Adding or the social supports would have added just 4 to 8% of the cost to the total essential package, higher in Rwanda, where so many patients in 2015 were living in extreme poverty. So the final point is an integration of palliative care into healthcare systems, including home care, has a lot of benefits. By reducing dependency on hospitals and even hospital inpatient and outpatient services, palliative care integration can provide financial risk protection for families because they can often get the care they need in their home or in the community. It can reduce overcrowding in expensive referral hospitals, and it can reduce costs for healthcare systems. There are startup costs that are needed to train staff and to hire additional staff, but there's evidence that over time, it can reduce costs for healthcare systems by reducing unnecessary admissions to expensive hospitals for symptom control that could be provided in the community. So lastly, I'll show this patient who I met in Rwanda at Sehashuka at the Kigali Teaching Hospital, who had been suffering from this osteosarcoma for weeks, had been unable to sleep, in terrible pain, 10 out of 10 pain for weeks and weeks, becoming more and more cachectic, didn't eat. And of course, when the child is in distress all day long, the mother doesn't sleep either. So he came to the hospital, and you can see on the left side a simple syringe driver. There were only 2 in the hospital, 2 or 3, and they were in surgery and in the emergency department. So we, shall we say, borrowed this pump from the emergency department, and I gave Mr. Jean-Claude was his name, and he and his mother gave permission to show this. Gave him 2 or 3 boluses of morphine, and he had complete pain relief. And based on the 2 or 3 bolus doses, I started him on a continuous infusion with this infusion pump or syringe driver. That made him comfortable. He was able to eat. He was able to play with other kids. He was able to get in the CT scanner to assess whether this might be curable with amputation. and he was able to get the amputation, and post-op did very well. That's palliative care that can actually sometimes contribute to cure. And if we're not doing it, if we're not integrating palliative care into cancer care, that's not the first-rate cancer care. So I'll stop there. Happy to discuss. Again, thank you very much.
Thank you so much, Dr. Krakauer. It was really an excellent and very relevant talk to our work, and it underscores the importance of building palliative care infrastructure in all the places we work. We have some time to open up to the group for questions. I have one, if I could just get it started. I've seen your graphic before and was really struck by it about the wide variation of morphine use in different countries across the globe. And I understand that the lack of pain medication utilization is really multifactorial and varies in different countries. I still don't understand, though, if the primary barrier is drug availability and cost and country regulations, or whether an equally or very big factor is also kind of the lack of comfort and training and prescribing and monitoring patients among rural healthcare providers who are trying to deliver these medications. And I was wondering if you could just comment on that.
Yeah, thanks, Scott. It's a complicated question that I didn't understand either, and I looked into it a bit. And you know, as you say, it's multifactorial. But as with so many of the problems around the world, this one can be traced back to colonialism. I think to a lot of the problem is what the Europeans did around the world. So it's a very long story, but in Asia, as you may know, the Europeans, the French, the British especially, the British East India Company was the biggest drug cartel the world has ever seen. They grew the poppies in India and they shoved it down the throats of the Chinese, as the French did to the Vietnamese and the Dutch did to the Indonesians. As a first, as a way, they basically had quotas. They required the colonized people to buy the opium, and they used the money to support their colonial regimes. And then they realized that because of the addiction that can be generated, that it also was a means of social control. So there's this great antipathy to opioids because of that, and then also because injection drug use drove the AIDS epidemic. So there's that fear. But the other thing the Europeans did was in the 19th century and early 20th, when the Europeans realized the potential for addiction, they proscribed, they forbade use of opioids in Europe and then in the United States. And this was linked with the, what's it called? The forbidding of alcohol, the temperance movement in the US and Europe when alcohol was forbidden for some years. And this forbidding of opioid use was written into the laws of the colonies, for example, in Africa and in South Asia. And when the independence movements happened, a lot of these really strict regulations against prescribing or any use of opioids remained in the laws because countries had to start somewhere. And so they took on the laws of the colonial powers. You know, in Rwanda, Dr. Agnes, the former Minister of Health, worked with an American lawyer whose name I don't remember now, to go through all of the health laws in Rwanda that no one knew that had been left over from the Belgians, because there were all these laws that had never been repealed or changed, and they were just sitting there. So that's a lot of where the overly restrictive laws come from, and that's also influenced opinion. Now, medical education is also at fault because people are taught that there's a great risk of respiratory suppression and a great risk of addiction, and neither of those are true, at least not in most patients. Some patients have a risk for opioid use disorder, and we can identify risk factors. Respiratory suppression is extremely rare if international guidelines are followed, but doctors are taught that it's a very big risk and they're afraid to use it, and they're afraid that their bosses won't let them use it, and their bosses are afraid that they'll get in trouble if they allow their staff to use it. So there's all this fear, there's all this misunderstanding, and it's not easy to overcome. I think that's a very oversimplified response.
Thank you so much. Maybe we can open it up to the group if anybody wants to jump in.
Yeah, sorry.
Oh, go ahead.
Okay, so Dr. Nikes from Utaro. Thank you so much, Professor Eric, for a very good presentation, which is very helpful and fruitful. So maybe this is another specialty. Really, I realized that we don't know really palliative care. So my question, first question, so among the drugs, essential drugs for palliative care, because here I'm talking about oncology, because oncology. So among drugs, essential normal package for palliative care, I don't see chemotherapy or surgery or radiotherapy. When we talk about palliative in oncology, because you separate this presentation, like you separate clearly palliative and primary treatment, oncology treatment. Is it separate, or is it also a component of palliative care? That's my first question. Second, normally when before going to do oncology, I did internal medicine, and we used to solve those chronic diseases like hypertension, diabetes, HIV, and so. But that aspect of palliative care was not listened so much. For those treatable diseases like hypertension, even in oncology, like CML, for example, it's a cancer you treat, the patient can be well, can stop sometime, even treatment. So, and no much. Can you really use palliative, or for those treatable and hypertension, you can live for a long time, all your life, diabetes, and even CML, I think, or rheumatoid. So is it the correct term you can use, or there is the other things? Thank you.
Thank you, Dr. Nikes, and great to hear your voice. And I hope to see you again in Rwanda very soon, probably this summer. So yes, you're absolutely right. In fact, chemotherapy is often given with palliative intent. Radiotherapy, palliative surgery, absolutely. And in fact, we created not only an essential package of palliative care. I only spoke about the essential package. We also created an augmented package of palliative care that should be available whenever possible. And that includes everything you said: palliative chemotherapy, palliative radiotherapy, palliative surgery. We've published with PIH colleagues on palliative surgical care. And I'm actually now working on a project with the International Atomic Energy Agency to make very clear around the world the importance of palliative radiotherapy, and that palliation is an important reason or indication for radiotherapy. So you're absolutely right. There's not a clear distinction between disease-modifying therapy and palliative care. They're really not distinct. And this gets to your second question, even when a disease is manageable or curable, there may be need for palliative care. Is the patient suffering? And is the patient suffering? And if the suffering is not entirely relieved by the disease-modifying therapy, there's a role for palliative care. So let me give you an example. We had a young patient here, even in Boston, who had terrible wounds from calciphylaxis associated with an episode of renal failure, acute renal failure. Calciphylaxis causes extremely painful wounds, and she could not tolerate the dressing changes. The wounds were so terrible, and we had her on very high doses of opioid, but it still wasn't effective, and she didn't want to have the dressing changes. She didn't want to have the wound treatments because it was so terrible, so painful, and we couldn't induce unconsciousness every time she had her dressings changed. So we used ketamine, which sometimes has a very good palliative effect, along with high dose opioid, and we found the doses that provided relief. She was able to get her intensive treatment of her wounds, and she was cured. She's healthy now. So that was palliative care for someone who could be cured, or someone with MDR-TB who can be treated and cured, but the side effects are unbearable. If we treat the side effects aggressively or provide the social supports, as PH often does, maybe they're cured. So palliative care is not only for end of life. And then you mentioned the term, what's the correct term? Palliative care in Boston needs to be different from what it is in Vietnam or in Rwanda or in Senegal. So I always encourage my colleagues, don't use the term palliative care. I've never liked the term. How would you translate palliative care into Kinyarwanda in a way that makes sense and is not frightening for patients in Rwanda, or into Chichewa in Malawi? What is a term that fits in the Rwandan tradition that captures this idea of promoting comfort and holistic comfort that makes sense in Kinyarwanda? I'll stop there because I see there's other questions, and I'm happy to stay a bit longer. Please, Dr. Hassan from Lesotho, if I'm correct.
Yes, good afternoon, Doc. How are you? Yeah, I was enjoying not enjoying service. I was actually seeing what is palliative care in all through your presentation. It exactly said everything about the definition and understanding of palliative care. I would like to thank you for that. Actually, like I was also a little bit like thoughtful about the question, doctor, that the Rwanda doctor asked you just now. So I will go with your thing, but palliative care can be used because it can be used, as the doctor was asking about hypertension. Yes, it can use to any life-threatening illness because it's a holistic approach, as Dr. Eric has mentioned. And the specific therapy, radiation, chemotherapy, or surgery, it will do, but it should be accompanied from the very first day of diagnosis of a life-threatening illness, right? That's what you said. It's not only the terminal illness, the term of palliative care. So it should be started from the very first day of diagnosis of cancer or other life-threatening illness. So in Sankatan Oncology Clinic, where I work in Lesotho, we have started a system, a sort of system here. Erin was here, and Sarah was here to be with us for a few weeks. So when the first diagnosed cancer patient from different corner of the country comes to Sankatan Oncology Clinic, the very first interaction will be with the palliative care team. The reason is to close the gap between the patient and the relatives and the healthcare providers, to let them understand their problem, the disease, and let us understand as a healthcare provider what do that individual patient need from the healthcare providers. I think that's it. That's my understanding. And my question is to Dr. Just for better understanding. Doc, like Asia, you have mentioned that there are so many approaches of palliative care. So in India, and I come from Bangladesh, there are palliative care volunteers. Okay. So do you think, is there any need of palliative care volunteers in the team to help the patients with life-threatening illness? Then we can make a training plan with PIH and our Sankatana clinic in Lesotho to train the volunteers also. What do you think? What is your suggestion, please, Doc?
Thank you, Dr. Hassan. Yes, in many places in the world, including here, even in the US, volunteers are very important. The community health workers can do a lot, but if they're volunteers, often community health workers are volunteers, but volunteers in each community who can sit with patients, who can help the family with cleaning, with cooking, or just accompanying patients, can be very important. And also spiritual supporters are often volunteers. Just one word of caution. I do think there needs to be some screening and some training of volunteers, because sometimes very well-intentioned volunteers and well-intentioned spiritual reporters can do some harm. So for example, there's some beliefs that some cancers are a kind of punishment for something that a patient did wrong, or that pain is something that should be tolerated, and you shouldn't accept pain relief. So I think volunteers should be encouraged, and it can be also very wonderful for community members who to do something that they can be proud of, that they can contribute to the community, that they can feel useful, and can be very good for patients and families. But I think there should be some screening and some training about how to avoid some topics, and try to be sure that they won't inadvertently do harm. Thank you.
Thank you, Dr. Eric. Yeah.
There's a hand up from Mr. or Dr. Julius. And you're muted.
Julius, you're muted. Perfect.
Ms. Julius.
Sorry, we still can't hear.
Oh, Julius, we can't hear you.
Maybe in the chat. We still can't hear. If you could put in the chat. We heard your voice for just a second and then it cut out again. Let's see. Oh, there's a lot in the chat. Erin, have you been monitoring the chat? I haven't.
Yeah. It was Dr. Hassan's question.
Okay. Okay. This is from Julius. Thanks for this. Is it possible to share this presentation? Yes. Yes, we can. Yeah, we can share the presentation. Yes. And what else do we have here?
I have a question.
Yes, please.
My name is Eladri Yengamanzi. Thank you for the nice presentation. It's really interesting, and I wanted to ask how to integrate the palliative care in the community. What is your advice when? Because a lot of our patients, our wards are very small. They have a lot. They have to go back to the community, and you have the community which are not prepared to welcome the patient who are on the long-term treatment and have different problems. What is the approach do you think can be good for the integration of palliative care in the community? Thank you so much.
Thank you. Yeah, so that's the ultimate goal, is to make palliative care accessible in every community. And from my understanding of the healthcare system in Rwanda, there's no low-income country or anywhere near the economic category of Rwanda that's better prepared to do that. So the tentative plans that we have for Rwanda, which we've actually been working on and have tried to pilot in the past, but we weren't able to sustain it, partly because of COVID. We're hoping to create with Dr. Sarah, working with Dr. Sarah Slater, a very strong palliative care team at Butaro, which has ideally a full-time doctor and nurse doing palliative care. There's a wonderful, in fact, one of the most amazing palliative care teams I've ever seen at Butaro, but everybody is so busy doing other things. So I think to have a really functional team doing palliative care every day there needs to be a full-time doctor and nurse, and that can then serve as a training site. A next step will then be to try to integrate palliative care into the districts. And we might begin with Burera district. In the past, we were also worked in Gasabo district and at Kibagabaga Hospital in Kigali. But it doesn't really matter which district. It could also be in Ringwavu, to train and build some palliative care, small palliative care service at district level, and then to provide basic training in palliative care for at least one and ideally two nurses and maybe also social worker at each community health center in the district, and also then train the community health workers, as I mentioned, to at least to recognize when their symptoms are not well controlled, if the patient's pain is not controlled, if they're vomiting, if they're bleeding, if they're short of breath, recognize if there's no food in the house, if there's no school tuition for the kids, if there's someone coughing who might have TB and is coughing, sharing the same bedroom, all of those things, and report it. So train the community health workers at least to be the eyes and ears of their supervisors at community health center. And then to expand from district to district around the country so that eventually the entire country is covered. And then when you send a patient home with cancer from Butaro or also from Kanombe, that the patient's, the community health center nearest to the patient's home would be informed, this patient is coming home. They're on these medicines at these doses for pain, and they also have some nausea and they're on these doses, and the pain might get worse, or they might have some trouble breathing, and this is what you should do if that happens. That's the model that we foresee for Rwanda, that there are people with some palliative care training at each level of the healthcare system, community health workers, nurses at community health center, doctors and nurses at district level and at the high level, but beginning with the high level, which can then be the training site for staff at lower level. That's in a nutshell the proposed plan.
Yeah, that's nice. I hope it will come first.
Yeah, let's do it. Let's do it.
Yes.
So I hope to be in Butaro in the summer, and Dr. Sarah will be there, I think, in March, in a few weeks. And
I will be around.
So Eric, maybe if you have time for maybe one more question,
Sure.
and then people can reach out to you by email.
Yes.
Was there one more question?
I think Viola.
Oh, it looks like they just, that was Viola. I think that might have been Julius. It looks like they just dropped. But I sent him an email, so if he has a question, I can send it along.
Great. Well, I think we'll wrap it up. Eric, we can't thank you enough for a great talk, and we all appreciate the really important work that you're doing to strengthen palliative care throughout the world, and specifically with our teams as well. So we look forward to continuing the conversation. And thank you for everybody who participated and stayed on the call, and we look forward to the next one. We'll give you a heads up about what the next topic is. And I also would encourage anybody to reach out to Aaron or myself if there are topics that you'd like to be presented at this forum. We want to keep it fresh and interesting for everybody. So everybody have a good Thursday. And once again, thank you so much, Eric.
Thank you.
Thank you, everyone.